Can't train the muscle.
Young handsome man, half my age. Normally, case history, again, is essential. If you just listen very carefully and you have your anatomy and you know your neurology, you'll be able to nearly make a diagnosis sometimes. But you have to differentiate things. But as I said before, if you have a disc irritation, it doesn't have to be a hernia. It can be a small protrusion, small swelling. You nearly always have pain upon flexion. Taking your shoes and socks on in the morning, prolonged sitting when you want to raise up again, you get pain until you get moving, and it's better lying down without vertical compression on your spine. So that will tell you a lot about it. So if you want to see if you've got some facet joint irritation too, then you may put your fingers on the spinous process, just to the side, and you want him to lean backwards. Sorry. And I want to pull him backwards in a slight angle over the joint. I'm not touching the muscles, I'm just touching the spinous process. Is that painful?
Not
really?
Maybe you should turn him around.
Yeah.
We don't want to see his face.
So you sit down here. So you want to compress the facet joints to see if there's any irritation in them. So you slightly rotate the patient to the side, while you press in on the spinous process and put them in extension. And you press in here without touching the muscles. So, and you ask, any pain there?
No.
You do that to the other side too. You can also do that in rotation if you're in doubt. So you actually come right here and try and rotate the facet joint to see if there's any pain. But then you won't be isolating the facet joint. Then you're putting torsional stresses into the spine, so you have a little bit of disc irritation. You can also provoke that. So just do extension and rotation and touch the spinous process. Lie stomach down, please. Face down.
Thank you.
Okay. So this is the most relaxed position to put the patient in here. If they're very much in pain, they'll still have spasm of these muscles here. So it's very hard to palpate in depth. As I just showed you, the multifidi are lying 4 centimeters down with a guy like this size here. So you really have to use pressure. So you find the spinous process and you go slightly lateral. And then you go down and compress the muscles. You go to the other side and compress the spinous muscles. Painful there?
No.
Not so much. You go down over the joint, the spinous process, just spine, and you press it straight forward. Painful too. As I showed you, the anatomy of the spine and the facet joints are sagittally. So they're sagittal. So if you spring it, you won't affect with the amount of motion here, the facet joints. You will put a shear force into the discus. So if there's some irritation around that and the tissues around that, that will cause pain. So he probably has some small degeneration, which we all get during life episodes, which causes spasm of his deep paraspinal muscles. And when he tries to stand up, he's had this for several days, so they just lie down there and hold him there. So you don't get a normal glide and don't get normal regeneration of the disc lesion. So it keeps on perpetuating itself. So you have to normalize these muscles here. So what we're going to do again, we're just going to take this machine. And this time we have to replace this one here. So we had 2 centimeters here. We're going to take that off. So I just clean this.
My pain tolerance is very low.
Yeah, but I'll be gentle.
I did tell my doctor.
I'll hold your hand while I clean it. There we go. So we got 3 centimeters. So we're actually gonna hit the targets from 2 to 4 centimeters. So I'm just going to get the posterior neural arch and the deep muscles down there. So I'll put this on 0 here. I use my little pen myself.
what would be the effect if you only use a 2 centimeter instead of a 3?
With a woman, tiny woman, I would use 2 centimeters. So your experience and your examination will let you know. If I stand like this and I'm able to put my fingers in, I can make a visual impression of how deep can I put my fingers down. And I always go a little bit short of that. If you go into the sensitive tissues around the spinal canal, the patient will feel it immediately, and you just stop. You won't cause any harm by losing these dosages just for a few shots. Don't worry. If they don't feel anything at all, you're too shallow. So if you're in doubt, use the lowest depth and then increase it if you're getting response. So again, I need a visual marker, so I go in here. That's painful. So I go just lateral here. And lateral here. And due to the size of the spinous process and the layers of ligaments and muscles over there, you have to go even more medially to actually get to the deep motility down there. And we go in here.
But I actually saw that you have another trigger point, which when you touch him towards on the left side,
Yeah.
there is another trigger point. Don't you want to hit it or just these 2 points?
I think the trigger point is deep because when I just touch superficially, there might be some. We got the spinalis, we got the longissimus, the ilicostalis, the lumborum, and then we got the quadratus lumborum overlying the multifidi. But they are always hypertonic. They're less. They're just sensitive. They don't that often have trigger points which give that deep aching pain upon movement. So they're accessory trigger points. We want to go to the deep paraspinal muscles. That's always where you find the quickest result here when you treat them. So there's a little foot piece here too you can use if you want to do that. I never use that. I find it's much faster just to turn this here on. And then I have to control 2 things. And I sit like this, and then I start curling around here. So I start over here, and I start very slow. And you grade the pain from 0 to 10. Yes. And when it gets better, you grade it again. You tell me all the time where it is, okay? So we're going to start here. So I make sure that I'm in the right place. I don't tuck the skin or anything when I just done marking. I'm very precise at going down here. Oh, we are here. And we'll start here. Any pain here? Good. Any pain there? Good. So I start going up. The deeper the tissues are, the higher energy you need to use. Yeah? I'm just going to search around. Pain there? Okay, I'm just going to angle. Okay. More. Is that okay? 5? Okay. Where do you feel the pain? Just back?
Yeah.
No, into your buttocks or up the spine or into your groin?
No.
No? Just going to angle a little bit. You still feel it there?
Not big pain.
I'm just going to search a little bit. Now I'm angling it slightly medially. Okay, we're going to stay here. And the pain still in the wrist spine?
Still here.
Yeah. I'll just stay at 6 for him. Otherwise he'll jump off the table. So this treatment protocol is just a guide. You have to take the pain perception of the patient in here.
Is it for some people they can tolerate higher?
Yes.
Or
Some
it's
can.
different one from
Yeah, we know that from everybody. It's different how we tolerate pain and how much the nervous system has been sensitized. We don't understand the mechanism, but if we have real facilitated pain patterns, you can just blow them on the skin and they'll react with a hard spasm. But if we want to keep getting some pain inhibition, we need to be guided by the pain from the patient. Is it still? 6? Okay. We're quite high. We're already at 0.3 millijoules, so we are in the area where we want to be. And I just wait until it dissipates. I have to get the neurological response, so I have to wait for that. And with some very painful patients, you have to give 2,000 or 3,000 shots before they start feeling something. And with some, it doesn't happen the first time. It will first happen the second and third time. How's it feeling now? What? 6?
5.
Good boy.
5. Better now.
What level is it on now?
5.
5. Still the same?
6.
So I want to stay as high as possible for patient toleration. The higher energy, the more I can stimulate the nerve, the faster you'll get the pain response. So you're no good at being nice to the patient. They have to feel it, and if you can give them 3 treatments and a total different pain level, they'll be grateful in the end. How now?
5 or 6. Between 5 and 5.
Perfect. I give him 2,000 shots, first treatment, and he's quite sensitive, so I'll just leave it by that. Otherwise, he won't come back for the next one. And we start the other place here. So I go over here to the other side. Even though he wasn't that palpatory tenderness, you will always have a bilateral response around the spine. You have 3-dimensional movement. You cannot only have a unilateral spasm. As we saw on all the MRI scans done with disc patients, you always get the muscle atrophy of the muscles. You get them bilateral, even though they have pain one side only. So you have to treat both sides. You have to, here, I think my theory is not only getting them out of pain, but it's also to induce some biological responses in the deep paraspinal muscles. So we get development of new, healthy muscle fibers instead of fat fibers. You start here. Can you feel anything here?
Yes.
How bad is it?
3. 4, 5, 6. Wow.
When you start out with this and you're not used to it, it'll take you a long time just angling it. And now I've done this so many times, I find it quite easy to do it. And I've got a steady hand, but when you start out, it's not as easy as it looks. Sometimes you have to search around and you have to angle it just half a degree before you get the right response. And now?
5. 6, 7.
We stay there. So, have you tried shockwave therapy on yourself? The thing with shockwave therapy is that we actually, when we treat muscles, the patient accepts it better than when we treat ligaments and cartilage, because here we produce a pain which the body knows. They know myotomal patterns. You're used to getting tension headaches and back pains from muscles. We know that pain. But when you're going to treat a tendon or a joint, you'll get a sclerotomal referred pattern, and that feels totally different. It's like an electrical, deep, radiating, deep pain. And when the nervous system experiences a new pain, it goes crazy. So you have to be more gentle with those tissues. And now?
Now 6.
Is there any patients couldn't receive the shock wave, was like a very sensitive person?
I think if you just do it very slowly, and sometimes the first treatment or second treatment you won't get up to the levels that you want to do, but start out slowly, because even if you do it slowly, you start desensitizing the tissues. And the next treatment you can use more energy. It just takes longer, but you get the same result.
After the first treatment,
Yeah.
I mean this indication.
So pain is psychological too. So you have to take that into consideration. That's why you have to pretend like the patient is in charge. Yeah?
Is there any difference between the protocol for pain moderation and for tissue healing and also for scar tissue?
I think the protocol here is mainly developed for treating spinal problems, to actually cause normal neurovascular responses again. We know that the key to spinal pain is actually to normalize the pain pathways. And we can only do that by hitting like the sensitized areas. So we need to be more aggressive, and we have to really deplete the areas. So you have to hit those unmyelinated nerve roots with more shocks at higher levels until they start dissipating. So you have to keep it on faster. Because we know that pain around the spine elicits so many bad things. It causes increased tension and bad joint movement. And if you don't get that under control first, you'll never get a healthy spine again. They'll always have some rest symptoms. So, and I suggest with every patient, treat the pain to start with. And then you can do proper rehab afterwards to regenerate things here. But it seems like shockwave in these doses, they both cause regeneration and pain modulation. But if you use a higher dose, like I do, and I stay on the same area for a longer period of time, you get more effective desensitization of the tissues. That was it. You survived.
Yeah.
Hello. Congratulations. I start. I always use the highest frequency. You can sit up again. And the reason why you read that you should use between 3 and 4 and 5 in frequency is that the studies which are actually behind this are from the old machines, who could only do 3 or 4 impulses per second. So that's why you recommend it. But we also know from empirical practice, the more energy you can deliver in a shorter period of time, the more you're going to shock the tissues. It's just like giving painkillers for a pain problem. If you underdose it, the nervous system, it starts recognizing it, the drug, and you get not as effective a response as if you overdose it to start with. So if you're going to use pain medication, you use it properly and you give it the right dose. Otherwise, you're just going to sensitize the body so the nervous system doesn't take against it. So the initial therapy for pain, neurological pain, you have to do everything in the shortest period of time to manipulate it. We see that we have a big problem we did studies on disc product hernias who were very acute, and if you give too mild a medication, not effective enough, they respond very, very badly. The nervous system gets used to the medication, and it doesn't relax the same way. So you don't get the pain inhibiting properties proper. And it's the same theory about this here. You have to go full in to get the right results. That's why I want to keep it up at 7 scale, numerical rating scale. It's just what the patient can take, but then we can deliver most of the neurological feedback for the tissues.
You usually treat types of difficult patients. First one is failed back surgery syndrome, and the other one is fibromyalgia.
Fibromyalgia is not a good diagnosis to treat. Fibromyalgia does not exist. It's as a diagnosis. It's a neurological problem. It's a brain modulating problem. It's not muscular. It's a neurological misinformation from the brain. So it's you can treat them and they respond a little bit, but if you over-treat them, they respond badly. So you have to treat them with medication. And often the only thing that they actually respond to is antidepressant medicine for a long period of time. That can actually show the sensors who sensitize these areas in the body. They respond very well. That's the only thing that actually keeps them moving. So fibromyalgia is a neurological problem. It's not a muscular problem.
Fail back.
Failed back syndrome is a whole different thing. If you operate a back and destabilize it, it's very, very hard to treat them. You're missing some anatomy which is going to stabilize your back. And it's very, very hard to stabilize. We don't have the same results at all with decompressive spinal surgery. So you're missing some part of the body. And the back doesn't like that in the long run.
A lot of scars there as well.
Yeah, scarring tissue, and even the most brilliant neurosurgeon, he cannot guarantee that the body doesn't respond with a lot of arthritic changes and scar tissue formation. So it's a last resort. That's why we want to keep it away as long as possible, and try every other way out with disc hernias too. But the key to that is proper pain medication to start with, and they have to stop any form of activity that actually causes pain, and then you have to start rehabilitation straight away.
What is the guideline for choosing the frequency?
The guideline, I say, crank it up, 8. You only use a lower frequency to actually to get the patient to take against or accept the treatment. We find much better results by using the highest possible frequency than a lower frequency. And that's confirmed by all my colleagues. So when you treat the back, use the highest possible frequency on this part. We have other manufacturers in our clinic too. Electromagnetic shockwave therapy equipment. But they don't have the same pain inhibiting properties like the pizza wave has. It's a more condensed and stronger shockwave than the other ones. It's smaller, so you have to be very specific when you use it. But the pain inhibiting properties are much better with the piezoelectric technology. And I think that if you want to stimulate something, nervous system, you have to go all the way in and do it the first time. You have to actually alter a very fine-tuned and complex system. And you only do that with a long-term standing problem by shocking the body. Don't let it adapt. Then the spinal system will just adapt to the pain and start producing the same inherent pain patterns.
Do you sometimes target at the facet joint if you clinically find it is a facet pain?
Yeah, then I
instead
go a
of the
little
muscle?
bit further down and I try to target both things.
Would you use the ultrasound to locate the facet joint area?
Yeah.
Yeah, because you can see the facet joint.
I
by
can
the
see
ultrasound.
just the start of it. So I go different places in the spine. You have to be good at differentiating the facet joints and the lamina and medullary processes. You know probably from the anatomy that would lie half a centimeter further down, so I'll use another gel pad. But only after I actually examine the patient. If there's no facet pain, and if there's good movement of the joint, but it's mainly muscle spasm, I'll target my treatment at that. If you're in doubt, try and use different gel pads to see what produces the patient pain.
So will this problem with shockwave?
Sorry?
Will this problem? That means they have sensation change, they have loss of power.
Yeah, but you don't treat the disc, you treat the biomechanical alterations around the spine. So if you relax the muscles and start proper proprioception around the spine, the disc will actually heal much faster.
So you do it in a very acute phase.
I always treat the surrounding musculature with these problems who don't respond. What we see, the disc is an avascular structure, and only the outer few percent is actually innervated by nerves. And that only causes localized pain in the deep aching pain, not very strong pain. What gives you the pain is the inflammatory process around the nerve irritation. So it's not, as we thought in the old days, it's a big bulge pressing out on the nerve. No, it's the inflammatory process that we actually regulate. And shockwave goes in on a biological marker point and actually changes these biological processes which are happening in the tissues around the nerves. Nerves produce much higher levels of these neuroenzymatic problem enzymes or hormones which actually cause pain. And we see when we use shockwave around that, we deplete these outspilling of these substances very quickly. So we overstimulate the nerve, so it actually stops producing these painful substances. So you're triggering the nervous system to stop an inflammatory process, and just by decreasing the inflammation, you decrease the pressure on the nerve roots, and you decrease the spasm of the muscles. And the key point to actually getting disc hernias better is getting movement into the joint again. They have to get active movement in. But if they keep on producing pain when they move, they will tense up wrong, and the disc will never heal up again. So new research shows it's a chemical problem affecting the nerve roots. It's not as much as a disc prolapse. When we take an MRI scan of the general population, 30 to 40% will have disc hernias, pressing on the nerve roots when you look at the MRI, but they have no pain. So we have to actually look at it in another way. Of course, some have massive disc herniations, which we have to operate, of course. But the majority are chemical problems, which we have to manage. So with disc hernias, it's very, very important that you use the proper pain medication to trick the nervous system to start with. And that's an arcade with non-steroidal anti-inflammatories, cortisone treatment, and nerve-regulating medicine like gabapentin and antidepressants. You have to use it all. Go all in to start with. Then you get the best result. So there's no middle way if you want to get good longer-term results here.
Hello, Anders. I want to know more about the